Hello and welcome to today's Better Care Playbook webinar, made possible through the Seven Foundation Collaborative on using population identification strategies to tailor care for individuals with complex needs. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Emma Optoff, Communications Associate at the Center for Healthcare Strategies.
Thank you, Travis, and thanks to everyone on the line for joining us for today's Better Care Playbook webinar. I'd like to thank the Seven Foundation Collaborative for generously supporting the webinar. We're excited to explore strategies for identifying people with complex health and social needs, which is key to informing tailored healthcare interventions for targeted subpopulations. You can move to the next slide too. Thanks. So before we get into the topic, I'm just going to provide a quick overview of the Better Care Playbook for those of you that may not be familiar. The Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. The Playbook summarizes the latest research, offers practical implementation guidance, and shares first-person perspectives to inform providers and health systems, health plans and payers, and policymakers on strategies to improve care for complex populations. It is coordinated by the Center for Healthcare Strategies and supported by 7 leading healthcare foundations, including Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, and the Robert Wood Johnson Foundation and the STAN Foundation. Next slide, please. This is just an overview of our agenda for today. After our introductory remarks, we'll be hearing from our presenters at 3 healthcare organizations who will share their takeaways from research and organizational approaches to population identification. These presentations will be followed by a moderated Q&A where our speakers will field questions from the audience. So please don't be shy. Remember, you can submit questions at any time with the Q&A feature at the bottom of your screen. I'll now turn it over to Rachel Davis, who will introduce our panelists and provide a brief overview of why this concept is so important for improving care for populations with complex needs.
Great, thank you so much, Emma, and thank you all for joining us today. It's my pleasure to be introducing our wonderful group of presenters, all of whom are helping to lead the charge in advancing our thinking about population identification within complex care, which I feel like is growing in leaps and bounds in recent months. So each of our presenters bring a slightly different perspective, and we're really excited for you to hear from them today. As Emma mentioned, first we'll be hearing from Dr. Anna Davis, research scientist at Kaiser Permanente's Center for Effectiveness and Safety Research, and Michelle Wong, who's the director of Kaiser Permanente's Care Management Institute. Anna and Michelle will be describing research that they've led into different methods for identifying patients with complex needs and Kaiser's approach to applying this research and their own population identification methodology to their own subset of populations with complex medical and social needs. Next, we'll hear from presenters from New York City's public hospital system, Dr. Jillian Duguid-Gerber, lead physician at Woodhull Hospital's Primary Care Safety Net Clinic, and Anne Marie Young, the director of complex care for New York City Health and Hospitals, will provide an overview of an amazing resource that they've recently put together and released open source to the public to help other organizations implement population identification approaches. And we'll speak to how they've applied the lessons learned and the insights from this tool within their own work setting in a clinic that serves individuals with complex health and social needs. And then lastly, we'll hear from Jonathan Weidman, who's the Vice President of Population Health at Care Oregon. And Jonathan will really speak to the health plan's journey to developing and refining its own population identification approaches and the many lessons learned from that journey, including some of the insights that they've gleaned on how to better understand and support what we call rising risk populations. So before we dive into presentations and to help contextualize today's webinar, if we can go to the next slide, I'll just say a few brief words about this topic and what we hope you all glean from the presentations today. So the idea of population identification is really core to complex care, and oftentimes it is one of the first either implicit or explicit steps that happens or that needs to be taken to develop programs or interventions designed to support individuals with complex health and social needs. That being said, we know that this population is not heterogeneous. Historically, there's been a little bit of a one-size-fits-all approach to defining the target population, and I think in some respects that's just a reflection of the field still being relatively new. And now that we're sort of maturing, the field of complex care has been around for about a decade. I think we're really starting to understand that the effectiveness of complex care interventions really depends on whether they'll engage the people who will benefit the most from them. And to get at this point, we really need to start moving beyond this one-size-fits-all approach and get a more fine-grained understanding of the needs and the risk drivers within a population that we're seeking to serve, and then consider how those needs and risk drivers might translate into more tailored programmatic approaches, starting from the engagement phase all the way into care management. So traditionally, a lot of complex care programs have targeted populations that have been identified based on pretty broad categories, including cost, utilization, insurance status, or medical diagnoses. And I think part of what our presenters will be able to share with us based on their hard-earned wisdom is that we really can and should get more expansive in our sense of how target populations can be defined, and also more sophisticated in understanding what subgroups exist within the groups that we're trying to reach. And then I think the next step, once we think about how to get more refined in our understanding of who we're serving and what their needs are, is what the implications are, understanding the implications for tailoring care management approaches once we've got a better grip on who it is that is actually part of the group that we're trying to reach. So with that being said, I'll now turn it over to Anna and Michelle from Kaiser Permanente. And just as one final reminder, please type any questions that come up for you during the presentations into the Q&A box using that Q&A feature, so that we can get to as many of those as possible during the Q&A portion of the webinar. So with that, Anna and Michelle, I'll turn it over to you. Thank you.
Great, thank you, Rachel. And Anna and I wanted to thank you very much. Thank you very much to the Playbook team for the invitation to speak here today. My name is Michelle Wong, and as Rachel said, I'm a director at Kaiser Permanente's Care Management Institute. And in this role, I have been working with the team at Kaiser to support our Kaiser members with complex needs. If we go to the next slide, before I turn it over to Dr. Anna Davis, I wanted to first start off with some background on CORAL, which is the research arm of Kaiser's complex needs work. Early on, I would say our complex needs focus was on the innovation, evaluation, and sharing of local programs. However, there was also an acknowledgement that partnering with research could really help advance our toolkit. And in 2017, the CORAL research arm was launched. I will say it's a very deliberate partnership between Kaiser researchers such as Dr. Davis and Kaiser operational leaders and practitioners. And with support from the Garfield Memorial Fund, we were able to fund 6 research studies. Dr. Davis today will share 2 of these studies. The first will be a study that she led together with Dr. Michael Gould, and then she'll touch on work led by another colleague within the CORAL research program, Dr. Richard Grant. And at the very end, I'll close out our presentation by speaking to Kaiser's strategic direction for our complex care work and really how we are working to connect the research into practice. So with that, I'll turn it over to Dr. Davis to introduce herself and share this work.
Thank you, Michelle, and thank you again to the Playbook team for inviting us to speak today. I'd also like to acknowledge the members of our research team and to thank our sponsor, the Garfield Memorial Fund, for funding this work. The study that I'll be focusing on today was formulated around a very basic premise, the idea of the Venn diagram. During exploratory conversations around the Choral Initiative, clinical leaders remarked on the difficulty in drawing meaning from the complex care literature because of the variability in how patient populations had been defined. And our team proposed this descriptive study to explore in detail how much variation there was in the approaches to defining complex populations and how important those differences were in terms of the resulting cohorts of patients. While we never actually succeeded in visualizing our results in Venn diagrams, our idea was to try to characterize the extent of overlap between seemingly distinct complex population criteria. This was very foundational work, and it started with an intensive, pragmatic review of the literature. We cataloged the details of how patients with complex needs were identified and selected. And this work was published last year in Population Health Management, and we're thrilled to have it highlighted on the Playbook website. I'll focus on this work today. But our study included a second aim in which we then used data from our population of around 3 million adult members, and we implemented 25 different definitions of complexity and then explored the resulting cohorts of patients to understand the implications of the criteria decisions that were made. And this work is on the cusp of being published. It should be released in JGIM any day. Our paper on the pragmatic review covered 70 papers that were published in the literature. And within those 70 papers, we found 90 unique complex populations that had been assembled. For each of those populations, we abstracted data on about the population criteria that were used, both implicit and explicit criteria. And we itemized those criteria in all detail possible. Those criteria for each of the 90 populations are all contained within an appendix table to the publication, which is available online. We took those individual criteria then, and we began to wrap them up into subdomains and then domains of types of criteria. And then building on conversations with key informants and colleagues, including Rachel Davis and Melinda Abrams from the Commonwealth Fund and others who are on the call today. We applied ultimately a framework from the National Academy of Medicine to describe the intent of the different criteria types. The domains of cost and utilization-based criteria we classified as stratification-based approaches, which focus on separating a population according to risk level. The criteria related to age, income, health conditions, including both medical and behavioral health, as well as subjective criteria, alternately performed as segmentation methods, which are used to separate the heterogeneous population into more homogeneous clusters, or targeting or tailoring approaches in which people are matched with services based on individual needs or characteristics. An example of this might be polypharmacy or having multiple prescription medications and matching to a deprescribing intervention. Amid the diversity of approaches that we observed, many were similar in intention and really demonstrated schools of thought that we felt reflected priorities of individuals in the complex care community. High utilizer approaches, which were based on cost or utilization and were combined often with an age-based criterion, were the most common in our review. In fact, 75 of the 90 populations that we looked at had at least one cost or utilization-based criterion. Another dominant school of thought focused on clinically complex patients, and these specified criteria focused on health or functional status. And in some instances, these criteria were also combined with a subjective determination, such as a provider review or a referral-based process, reflecting, for example, a desire to narrow the population within those selected based on data. These different approaches were not mutually exclusive, and in fact, most studies employed criteria from multiple domains. Even within a common theme, we identified very broad variability in how specifically the criteria were operationalized. In general, the studies that we reviewed rarely discussed their approach for identifying complex patients or the process through which they arrived at their criteria specifications. They may have used expert opinion or past experience. They may have done exploratory analyses of their data. These decision-making processes were rarely described. The definitions that we observed varied on dimensions of multiple types. Some were predictive, others retrospective. They may have used a threshold approach. Thresholds in the cost-based frame may have been based on a dollar amount or a percentile of spending. There were also examples of specific types of costs being included or excluded, and that same type of variability was found in other criteria types, such as specific medical conditions being included or excluded. And while there were surely reasons for the definitional choices that were made, such as the availability of data elements or the size of the population that was desired, we concluded that at a minimum, it was important to be more explicit, both in language and in detailed explanation of the criteria that are used and the rationale for selecting them. We concluded that while there are schools of thought, there was very great variability, and more importantly, that there was very little information about how important those distinctions in the criteria were. The vague language, such as high utilizer, does create the potential for confusion or about the comparability of populations that are seemingly similar or are talked about similarly, but may be specified in different ways. And so in our second paper, we dug into this conclusion by implementing definitions within our population and then using descriptive methods to compare the resulting populations. And this work, I provide the title and the journal here, and it should be forthcoming soon. I really hoped it would be out in time to share a real link today. But we hope that you'll check it out. So I was also asked to speak briefly about the work led by a colleague, Dr. Richard Grant, together with co-PIs from other regions within Kaiser Permanente. As part of the Coral Initiative, Dr. Grant's team undertook a project that's an example of exploring a particular definition of complexity more deeply to identify potential intervention opportunities. The findings from Dr. Grant's work were recently released in JAMA Network Open, and the paper is also highlighted on the Better Care Playbook. Dr. Grant's team asked what segments of patients exist within a medically complex population. They defined their complex population based on a set of criteria built around COPS score, as well as utilization of the emergency department and likelihood of hospitalization, a predictive risk score. Then using real data, covering a broad array of patient traits and latent class analysis methods, they uncovered clusters of more homogeneous patients that make up this heterogeneous cohort. At a high level, latent class analysis is a structural equations model approach, which can be used to identify unobservable clusters of patients that are alike within a heterogeneous population. It's a model-based and iterative approach that estimates patterns and patient characteristics and summarizes a patient population into a finite number of groups. The results that they found are driven by, in part, by the base definition that they used for complexity. But their model resulted in 7 patient profiles, which they were able to describe using summary data about the characteristics of the patients clustered into each of these groups. Then, together with key informants, including clinical and operational leaders, they developed interpretations of the clusters that resulted from their analysis and proposed possible interventions or actions that could be taken to better meet the needs of patients in that cluster. They concluded that while it was possible to describe clusters according to their shared characteristics, they noted that every patient in each profile had multiple other chronic conditions, and as such, care programs that focus on just their common trait would never suit the full range of needs that the complex populations had. So with that, I'll hand it back to Michelle to say a little bit more about how these research results are used within KP. Thank you.
Great, thank you, Anna. So yeah, we wanted to just share a bit about our strategic direction for complex needs and how we're trying to learn across our system. One thing to note is because Kaiser Permanente is an integrated system, we have both a health plan, a medical group, hospitals, and 8 different regions. It's in itself a complex ecosystem. But we also feel that this integration and complexity uniquely positions our organization to learn. And that just as there's a need to embrace the intersections in both in our complex needs patients, there is as well within our organization. And there's an opportunity to partner with researchers such as Dr. Davis, and she shared Dr. Grant's work, as well as our patients, clinicians, community partners, and our health plan and our 8 different localities to really bridge silos across these entities in order to improve care. One thing at the Care Management Institute, we have a saying, which is we need to make the right thing easier to do. And I think what we're doing here is really focusing on trying to understand the right thing to do for our Kaiser complex needs patients, and then creating systems to make it easy for our practitioners to do the right thing. Next slide. So our approach has really been to create a portfolio of learning activities, which are always connected to practice and to our care teams and patients. The work that Dr. Davis shared, the CORAL work as a broad set of research projects, is really positioned within our broader learning approach that also includes a focus on learning from local programs and innovations across the regions. So this learning approach has really been focused on supporting local teams by connecting them with each other and often supplementing them with supports like things like evaluation, patient and provider ethnography, standardized screening and care plan tools, and workforce competencies and training. The research that Dr. Davis shared and the research in general really plays a critical role in this learning approach. I'll say that the research Anna shared really highlights how our thinking has evolved, and I think Rachel references at the beginning, from sort of the earliest concepts of the high utilizing 1 to 5%, to more refined thinking about the integration of social, behavioral, functional needs, and now into this work even more so around how to think more clearly about population identification, as Anna has shared today. We're still learning at Kaiser, but we have a strong belief that connecting the research to operations and down to our care teams and our patients in both directions will be critical for us to learn how to best provide the care. So we wanted to both thank you for your time and hand it over back to Rachel.
Great, thank you so much, Anna and Michelle. And I think that presentation really helps lay an important foundation for the other 2 presentations that we have coming up next. So just very quickly before I turn it over to Anne-Mary and Dr. Duga Gerber, just one more plug to folks. If you have questions, please throw them in the Q&A chat box. We are keeping tabs on those, and we'll get to as many as we can during the Q&A portion. So, I'm sorry, Anne-Mary and Dr. Duga Gerber, I'll turn it over to you.
Hi, good afternoon, everyone. I just wanted to start by saying thank you so much for the Playbook team for inviting us to participate in this webinar. And I also wanted to acknowledge our funder, the Commonwealth Fund, for supporting this body of work. My name is Anne-Marie Young. I'm the Director of Complex Care at New York City Health and Hospitals. And I'm joined today by my colleague, Dr. Jillian Duguid-Gerber, who's actually a lead physician at one of our complex care clinic sites at Woodhull Hospital in Brooklyn. If you could just advance to the next slide. Thank you. So I just want to spend some time today talking about this resource that we developed, the Complex Care Operational Guide. Within it are embedded open source resources, clinical tools, and case studies with the goal of healthcare systems at any stage in their work on complex care to be able to review and use in informing their own work. In doing this project, our goal at New York City Health and Hospitals was to leverage the knowledge of our safety net healthcare system providers to really inform the complex care strategy within our system, and also to develop a segmentation framework based on their experiences and firsthand knowledge with patients. Can you obviously, for purposes of today's talk, we're not going to have time to delve into the entire operational guide, but I definitely encourage you to review the link to it at the end of the presentation. It was embedded in the previous slide. We are just going to focus a little bit on what we've done specifically at Health and Hospitals and kind of put that back into the framework of the guide. So in order to better identify complex care patients within our system, we actually implemented a predictive modeling approach. This allows for proactive population risk scoring, and it allowed us to generate a list of people who are likely to utilize services within our system, to cost the most, and are really at highest risk for poor health outcomes. And as I mentioned before, this operational guide includes open source tools. So there's actually a link here to a peer-reviewed paper where you can actually access our non-proprietary open source predictive model that we used in identifying patients with complex needs. Next slide. This is actually a snapshot of how we moved on to thinking about understanding and segmenting our complex patients. So we wanted to basically combine the analytics that we had worked on through the predictive modeling outcome along with clinical insight. So our data colleagues actually developed a patient dashboard. This is a very early iteration of the work that we did, and you can see that there are several action segments highlighted within this dashboard. So those basically correspond to what at that time were existing programs, and we wanted to sort of get a sense of, from our data, what was the volume of patients that would fit within those categories. Obviously, this was a very early approach, and it overlooked people whose needs extended beyond our existing clinical services. And we recognized that a more holistic segmentation approach was needed to fully understand why someone would be a high emergency department utilizer, for example. Next slide. So this is really the meat of the operational guide. This is the qualitative segmentation framework that we developed in collaboration with a cohort of providers. We conducted a series of focus groups and targeted interviews with them over the course of several months to develop this framework and really just to leverage their knowledge so that this could be a tool used out of the box for other healthcare systems to really better understand who their complex patients may be and what is driving that complexity. So I just want to spend a little bit of time walking you through the segments that we identified. The first critical point in time, so these were folks with mixed medical and behavioral health needs and primarily had acute care utilization driven by a recent life event. That could include the onset or diagnosis of a serious illness or the exacerbation of a serious illness. Next, there's the capable but conflicted segment. So these are folks who have very high medical needs driving their complexity, However, their acute care utilization may be driven more by individual preference. For example, existing primary care offerings may not have sufficient hours or availability to align with that group's lifestyle. So this can also be characterized by avoidable emergency department visits for primary care sensitive conditions. Next, there's the struggling to self-manage group. So this includes people with both mixed behavioral and medical needs, compounded by a limited ability to live independently. People in this group may have functional limitations or the need for skilled nursing services. Next is the disconnected by disparity group. So this is a mostly medical need driven group. However, social risk factors prevent them from accessing sufficient aftercare after a hospitalization, for example. And so as a result, their conditions actually can worsen, resulting in potentially avoidable readmissions and revisits to the emergency department. Next is the seeking relief from serious illness segment. And this is really primarily consisting of folks who have advancing care needs and needs for palliative care. And finally, the last segment we identified was basic needs for better health. So this is a mix of behavioral health driven and medical need driven population, but really what drives much of their complexity is that they lack fundamental resources to get well. Things like housing, food security, and social support really do have an impact on their health. Next slide, please. So based on those based on those segments, we actually also had a section all about treating people with complex needs. And so we define several care models that exist within the field of complex care that you can review. And we actually matched some of those models to the segments that our providers helped us to develop. And so as a result of this, this really helped us identify gaps in services within our healthcare system and helped to focus our complex care strategy as a healthcare system moving forward. I'm going to turn this over to Jillian shortly. She actually is the lead physician at a clinic that addresses the needs of two of these segments. It focuses on treating very high-risk homeless patients who we would be considering struggling to self-manage. They have a very limited ability to live independently, mixed behavioral health and medical complexity, as well as that disconnected by disparity segment. So these are primarily people who have mixed medical needs and significant social risk that's a barrier to aftercare and results in readmissions and emergency department visits. The model that we actually developed to address the needs of those two segments was an intensive primary care clinic. And if you could just advance the next slide, I'll turn it over to Jillian to talk a little more about the specifics of that.
All right. Excuse me. Thank you so much, Anne-Marie. I'm super excited to be here and share a little bit about our clinic, which we call the Safety Net Clinic, which, as Anne-Marie talked about, is an intensive primary care clinic that is specifically tailored to meet the needs of our patients who are homeless, who have complex barriers to primary care. So this may mean that they have really complex medical conditions that have them end up in the hospital over and over again for admissions. This may mean that they don't have phones and they can't get in touch with the clinic. This may mean that they can't get in touch with clinic in a traditional means or get medication refills in a traditional means. They may be undocumented, but what we did with the segmentation that Anne-Marie and the Office of Population Health at New York City Health and Hospitals created is we wanted to figure out, what does that actually translate to clinically, and how can we match all of the data that they had collected and gathered in all the qualitative interviews that they had performed, and how can we use that to actually serve our patients better. So our mission is to effectively engage people who are homeless, who have complex barriers to primary care, to provide dignified trauma-informed care, focusing on our patients' goals while addressing their chronic diseases, their mental health needs, which often does include addiction. And then lastly, to use our interdisciplinary care team model that combines primary care, clinicians, social work, nursing, care coordination in order to be able to provide as much in terms of wraparound services for our patients as we can. Next slide, please. So the staffing, because this is truly an intensive clinic intervention for people with complex needs, it does require a high level of staffing, which we have made the case for across the system and have been grateful for the staffing that we've been able to provide. So our patient team is really critical for our intervention to be successful. It does involve a primary care provider, a clinic nurse, a LPN or a patient care associate, a front desk staff that is also trained in trauma-informed patient care, and then trying to use all of the services that our health system can provide. Since we are a safety net system, we do have access to care coordinators. We have partnerships with outside organizations for supporting our patients in housing navigation. And we have at our larger clinic, we have a social worker as well, who's built into the team. So it really is trying to tailor our clinic staff and our clinic approach to the needs of our patients who just have a lot going on. Next slide, please. So our tips for how to replicate a pilot program for patients with complex needs is to start with your needs assessment and understanding what subpopulations you might have within your group of, complex defined patients, and then figure out how to make that simple and operational. So for us, what that meant was, we wanted to create a clinic for people who were homeless, who also were struggling to manage, or who were disconnected by disparity. So we felt that our high risk algorithm that was created by the data team would be a really simple way to distill some of that information. So all we need for our clinical referral for us is identifying this patient is homeless and this patient has the high risk flag in the system. And if they meet those two criteria, we say they qualify, and then allowing for clinical judgment along the way as well. The second important thing is identifying what resources you already have available, whether that's staff, whether that's space, and how you can best use them to serve your particular patient population. And then to start small and keep iterating, keep changing. Here at Woodhull, we're a very small clinic. We're just 1 day per week, but we're the second site. We're the second site of a clinic that has now expanded to nearly full-time at Bellevue Hospital as well, and we look to keep expanding. And then finally, you can't do this alone. Our patients are complex, and so reach out to the external organizations who might be able to work with you and share your mission and share your values. So look forward, if you guys have any questions, look forward to answering them more in the question and answer session. Thank you so much for your time.
Awesome. Thank you so much, Anne-Marie and Jillian. I just want to underscore what a fabulous resource that operational guide is. One of the things we hear the most at CHCS is we hear from folks all the time clamoring for resources that can help them implement various strategies related to complex care. And this is it. You have an amazing operational guide here that is specifically focused on how to implement some of these concepts. So just thank you to H&H and the Commonwealth Fund for supporting that resource and putting it out there, and just, again, really encourage everybody on the line to check that out. And I love the way that you guys have thought about categorizing different subgroups within complex care. And I think the next presentation that we have from Jonathan Weidman will just be a great sort of add on to that discussion and just showcase another way that in this case, a managed care organization has thought about identifying different subgroups and the different lens that it's come up with and the different categories, and really just showing the richness that exists within this topic here. So Jonathan, I'll go ahead and turn it over to you.
Thanks so much, Rachel, and thanks to the Playbook team for inviting me as well. Always very exciting to have these conversations, and I think you spoke really eloquently about it too, Rachel, that this has been a nice kind of iteration of how we've all been using these models. So I'm going to tell you a little bit about Care Oregon's models. So a little bit about Care Oregon quickly. We are a managed care organization, all Medicaid or dual eligible Medicare, Medicaid individuals in the state of Oregon. This is a little bit of a makeup of our population. We do lots of kind of different things within the safety net and the FQHC world. A little bit about our mission, very community-based for ourselves. I always say we're the little health plan that could, always trying to involve our communities in their own care. I'm mostly going to talk today about our population segmentation modeling for rising risk. In particular, the model does have all from healthy all the way to extremely high risk, but I'm going to talk mostly today about rising risk, which we have focused most of our energy as of late in that realm. A quick brief history for us at Care Oregon. I think, you know, we've heard from other folks the journey that has happened for a lot. Our journey is very similar. We started very early on with a partner, Collective Medical Technologies, CMT, and a very broad as they looked at data for folks who were utilizing the ED as well as inpatient treatment. And what we realized is there were some patterns, not surprising to folks, what they called stayer, joiner, lever. And that really sparked our initial thoughts around segmentation and how we want to start matching services to the right population. So when we looked at that initial data, we thought, gosh, we really need to start marrying the right intervention with the right population, very much like what I've heard my colleagues speak about today. And we started to look more deeply into the data beyond just utilization data to help guide our process. And that's really what began our journey in population segmentation. You know, our historical state, like many, was really based on this acute episode of identifying members who needed care coordination. So they would go to the emergency room, they'd go to the inpatient setting, and we would then intervene and help provide care coordination. You know, interventions were very reactive because it was based on an acute episode, and it was very much criteria based. So in order for a patient to get into the program, they had to meet very specific criteria in order to do so, which really was limiting us to do any kind of proactive identification to prevent an incident from happening, as opposed to helping manage the incident after it occurred. So our proactive future state was really about, and it continues to be, frankly, identifying members or patients prior to acute episodes. So before that inpatient happens, before that ED session happens, how do we get ahead of the game to help folks? How do we proactively outreach to members likely needing more attention? Again, not dissimilar to what my colleagues have spoken about. We call this the yours, mine, and ours intervention. We don't currently own our provider network. It's all contracted provider network. So really getting clear about what is the provider network's responsibility? What do they do best, and how do we help them do that best? What's ours, mine, as a health plan? What's my role in particular with a segment? How can I use my skills best as a health plan? And then what is ours to work on together, the provider network and the health plan? really using data, as we've talked about today, to identify the physical, social, and behavioral health needs of members and patients, and how they contribute to the overall health decline, I think is really the key here for us. And then how do we successfully disrupt or delay that process of health decline? So our current model, very similar to what we've heard today, is a process of putting folks into these segments to really understand, behavior patterns. What are we seeing here? Inform our resource allocation to address those specific needs, observe population level trends. Are members, are patients getting better over time? Are they getting worse over time? And then really, how do we identify member level trends by provider or clinic to inform opportunities for quality improvement and support? Oftentimes our contracted network really wants to do the right thing and they just don't always know who those folks are. So how do we help provide that right information at the right time for our provider network? We've talked a lot about segmentation. It's we are using a cluster analysis similar to what was discussed earlier to put folks into groups that help describe how they're currently using the system. These are some of our data sources: medical claims, pharmacy claims. We do use Johns Hopkins ACG as the backbone of the model. We have a variety of input variables that we put into the model. We create our cluster analysis, and then what we did is we took all of that together, and then we had our medical directors go through and start to assign what we call human labels to those things. So a cluster of folks utilizing the healthcare system in a similar way. How do we want to define that group of folks? And we really ended up with 4 distinct cohorts: healthy, low risk, rising risk, and high risk. Within each of those cohorts, we have a further breakdown into segments. In healthy, we have healthy kids, healthy adults. In low risk, we have acute kids and adults, moms and babies. In rising risk, we have 4 segments, what we call chronic managed, uncoordinated, complex managed, and chronic uncoordinated. And then in our high risk, we have high pharmacy, we have substance abuse and mental illness in one category, and then extremely complex in our high risk cohorts. I'm going to again talk mostly about rising risk. So here's a descriptor of 4 of our cohorts, or our segments within the cohort of rising risk. Chronic managed have at least 4 chronic conditions. 20% of them have some sort of mental health concern. They have 1 or more dominant hospital conditions, including diabetes, hypertension. These folks, though, are engaged with their primary care clinic. So they are attending primary care visits, and they do not have any significant ED or inpatient use. And then the next part below really describes some maybe interventions that we might want to do for that person, including making sure they connect with a behavioral health specialist in the clinic, or if they need a referral to specialty mental health, for example. And, just to highlight from our historical perspective, this would have been a person that wouldn't have been on our radar because they weren't utilizing the healthcare system in the way that we were functioning then. So they weren't using inpatient or inpatient or ED. So we wouldn't really capture them in terms of need, although clearly they probably need support as well. Complex managed, similar, have multiple medical conditions. They have also a high engagement with PCP, but they also have specialty engagement, which is also really critical to understanding this population. They have the highest rate of specialist visits in this segment. And then they also have a high prevalence of cancer and rheumatoid arthritis in this segment. For the other 2 segments within the cohort of rising risk, we have what's called uncoordinated, and that means they're using the healthcare system in what we would determine to be an uncoordinated way. These folks tend to be younger, in their 30s, with no actual chronic conditions, but do have a substance use disorder, and half of them or so use tobacco. These folks are utilizing the ED quite a bit and are less likely engaged with their primary care provider. whereas chronic uncoordinated have 4 chronic conditions at least, 2 hospital dominant conditions, and on average take a variety of medications. They have at least 1 or so unplanned inpatient stay and a couple ED visits, but again, are not what we would consider high utilizers. What I find most important about this group is that 50% of the members in the chronic uncoordinated segment are frail, and about half of them also use the ambulance. So when I start to think about rising risk, I really start to think about these folks who are chronic uncoordinated. So this is another thing that we've been really starting to dive into, which is how do we take our current modeling and how do we really start to create this conceptual framework of, okay, once you've identified these folks, how do you then get ahead of what you're really trying to accomplish? This is borrowed from some colleagues out of JAMA, published in JAMA, around patterns of functional decline. And we thought this is an interesting way of thinking about the trajectory of someone's illnesses and how would we match our segment to this trajectory. And so you can see here we put on the sides, high risk matches mostly with this kind of short period of evident decline, so they're doing fine, and then something big happens for them, versus the middle part, which is mostly what we would consider our rising risk population, which makes that population a little bit tricky as well, because they have these periods of doing well, and then some decline, and then back to base, and then down, but over time, that's really leading to some functional decline. So I really want to focus mostly on this concept of chronic managed, which I highlighted for you earlier. And if we were to take that and kind of blow it up and we were to say, okay, if we're looking at a long-term trajectory of illness that we want to get ahead of, what's really important? We focused mostly here. We focused when there was a decline, when there was an inpatient, and we said, okay, we're going to help intervene. We're going to get them back to where they were, or hopefully at least to baseline. And, really, though, what we want to look for are what are the meaningful signals that indicate there's a change in health status. It's beginning, right? We want to get ahead of it before they're in that inpatient. We want to be more proactive. We are currently playing around with a bunch of what we call signals to health decline, including, new durable medical equipment, such as a wheelchair or a walker, changes in medication, a new diagnosis, as well as using some new predictive analytics that we're working on. And then also, what are the meaningful signals that the end of life cycle is occurring? I think we sometimes miss that opportunity that we can say, hey, this person is probably appropriate for palliative care, and that's the right thing to be doing. And, we're looking at certain signals for that as well, a first ICU visit, a change in frailty status, as well as employing some end-of-life indexes, which folks have probably heard of. But ultimately, what we want to develop is a clinical strategy that is data-driven, covers disease state, life cycle, and truly right care at the right time. In this whole process, we've learned a lot. Finding the right signals is challenging. Our current model is not predictive in nature and needs to be in order for us to get ahead of the game. We need to develop a lens into the member impactability. So once you've identified someone and you identified an intervention, how do you know that they're impactable? How do you know you can make a difference? And that the language we use is really important, and we need to be simplified in our language to help providers and be more trauma informed with our members. So the next steps for us is readjusting our model to include predictive analytics, which will be what we call PopSeg 2.0. We need to develop mechanisms for indicating impactability. We're working on developing an impactability score. We need to test with clinic and community partners. We need to get clear on our roadmap of yours, mine, and ours. We need to work collaboratively with our network to build workflows for that roadmap, and then develop evaluation to determine true changes to risk status. And I will turn it over to Rachel.
All right. Thank you so much, Jonathan. And I feel like with these 3 presentations, we've really kind of covered a large part of the spectrum here of what the research tells us about the current state of how we're thinking about this, how different health systems have thought about using population identification approaches to identify, get more refined in understanding and identifying complex subgroups. And then Jonathan, I think you really have helped underscore that population identification strategies are just that. They're strategies that can be applied to lots of different groups. And so really love that you just took a deep dive into the concept of rising risk to just help underscore that a lot of the concepts that we're talking about today are really flexible and can support hopefully folks on the line think about their populations really broadly speaking. So with that, I'm going to ask our presenters, if they're up for it, to go on camera. We're going to move into the Q&A portion of the webinar. We've got about 30 minutes for this. And thank you so much to those of you in the audience who've been submitting questions. We've been furiously cutting and pasting and trying to think through which ones are the best ones to ask. So I'm going to take a stab at this and acknowledge just up front, we're not going to get to all of the questions that have been submitted, but we'll do our best here. So why don't we start with a question that a couple of different folks I think we're getting at in various ways, which is around how you all have thought about incorporating social risk into your population identification work. Historically, within complex care, I think that's something that we all understand is a huge driver of folks' needs and the way that they're able to manage their health and interact with the healthcare system. But also historically, we haven't had a great way of capturing social data and integrating it into things as formal as population identification algorithms. So just curious if any of you could maybe speak to the way that you've been thinking about social needs as it relates specifically to your population identification modeling.
So I can start off by saying that in our review of approaches to complex population definition within the literature, we observed very few papers that were using criteria that represent social needs. And we reflected this as probably partly because those data often are not available in discrete fields, although it could also have been reflective of our search strategy in our review. Michelle could talk a little bit about what KP is doing in the space of social need measurement, if that's of interest, but I also saw Jonathan ready to chime in.
Yeah, I was just going to pretty much say a lot of what you just said, Anna, that we don't have a lot of that data. So we're attacking it from a couple different angles. One is we're working really closely with our network providers to talk about using Z codes and how can we use Z codes to capture some of that, knowing it's not great in some ways, but there has been improvements with Z codes. How do we incentivize providers to use them? What's the purpose, et cetera? But how do we get that data back? At the same time, we're also working with partners like Unite Us, which lots of folks I think are implementing within their state to help capture some of that data that we'll get on the back end to then also use within our risk modeling. And then finally, we as a health plan have to do what we call a health risk assessment on all of our members who are coming into our health plan. And so we've actually completely pivoted most of that assessment to include all the social determinants of health and social risk information, and then incorporating that into our algorithm as much as possible. So it is, I think at the end, it is about how do we get that discrete data and how do we get the best quality data out of something that's super complex. So we're just starting that process.
Yeah, this is Michelle. I just wanted to add one more thing. So I think, as Jonathan and Anna said, I think a lot of it has been just starting by acknowledging the importance of social health as a part of total health. And then for some of our teams, it's, creating or thinking about domains that may be relevant. So like neighborhood deprivation index and so forth. But I think part of the work actually is to think about normalizing social health as just a part of overall health. And so thinking about ways to think about more universal social needs screening so that we can work more upstream. It's not as reactive. So they think that's part of the journey that we're pursuing at Kaiser, is thinking about, how do we really normalize social health as just a part of all of our health, and how do we really think about doing that screening more upstream?
One additional point that I wanted to just make is in our actual risk stratification tool that we use proxies for some social determinants of health. So if a person has a number of zip code changes within the last couple of years, that's one way we get, that they might be transient in their living situation. If they've changed insurances multiple times, that's another thing that we capture in the risk data. So that coupled with then like the clinical diagnoses and then Z codes, as well as like not in this algorithm specifically, but in other parts of our health system, we use Z codes as well to identify social risk and social needs.
I would just also add really quickly, we do have some embedded social needs referral platform within our electronic healthcare records. So while that's not currently in our algorithm, those can be tracked at an individual patient level. And I would imagine a future iteration of the algorithm would include some of that data. It's a relatively new piece of what we've been doing at health and hospitals.
That's great. And I'll just say a couple of things. One is that I already cannot remember which one of you panelists said this, but reference some of the publicly available data sets that are available sort of at the census tract level or the zip code level. And actually CHCS, I believe last maybe summer or fall, did put out sort of a resource sheet that just has a number of those publicly available data sets listed and a brief description of them. So we'll try and put a link to that in the chat in case that's something that's of interest to folks. The other thing that I just want to say is that we've had the privilege of interacting with, Kaiser and Care Oregon and a number of other healthcare systems over the last year or two around this idea of identification models, and this question of how do you factor in social risk has just been at the forefront of those conversations. And a couple of the folks that we've talked to who have really dug deep into this have said something interesting, which I would love to just throw out to everybody on the line on the participant side of things too. Like if you guys are finding this or not finding this, I'd be really interested in hearing this. But some of the folks that we've talked to have said that the social risk factors, when they've been able to call some of that data and throw it into algorithms, actually hasn't really meaningfully changed the way that patients have sort of been categorized. And their thinking behind that in the experiences that they've had there is that the social complexity is sort of manifesting itself in like physical health way, so comorbidities or the way that they're touching the healthcare system. I found that really fascinating. And I think this is still, sort of the part of like the frontier of population identification. And so, like I said, I'd love to hear from others if that resonates or not. But just wanted to throw that out there that, on the flip side of the conversation around like, we need more social data. We have heard a couple of folks say, you throw the social data in there, but like what we were seeing so far is that it actually doesn't really seem to change a lot of the modeling if you've got a strong algorithm in place. So with that being said, I will turn to a couple other questions that we've gotten here. And I just want to acknowledge, I feel like there's sort of two categories of questions. We're getting one around population identification strategies, and then a second category around like, how are you using these strategies to help build interventions? So I'm going to try and hit both of those categories here. So I think in the vein of continuing to explore a little bit around population identification methodology and approaches there. One question that came up, I think I'm interpreting this correctly. If not, I still think it's an interesting question, is to what extent have you involved either patients or members or frontline staff or clinicians in helping build out the definitions of these segments. You know, and sort of getting a little bit of a qualitative perspective on, you know, the quantitative aspects of the population identification work. Jonathan, I might pick on you because I know you've done a little bit of work in that space.
Yeah, I'm happy to talk about it quickly. I think on the provider side, really important, you know, that was a lesson we learned. I think, you know, we had our kind of internal staff originally kind of define the population and then taking it into the network, we realized that we had to do a lot of like training to help people understand what the heck we were talking about. And so that really helped inform it, but it did validate in lots of ways for us. We had a variety of providers in different regions within the state of Oregon who were really open and willing to take in that data and then see how it kind of stood up, you know, clinically speaking. And it really helped validate that we were heading in the right direction. I think, you know, the clustering worked, I think, the way we wanted it to. I think the language and the words we were using, we needed to shift and change and make it a little bit more like useful for a clinic to utilize. And then in terms of, you know, our patients, we have a variety of community groups that we host, you know, like you know, advisory committees and things like that with people who are our members within the health plan. And we most recently just started talking about this with them, and that's was part of the lesson learned that I put in there as well, is, you know, their feedback to us was the labels you are using are not very trauma informed, you know, and so they were saying, I don't want to be called that. Like, why are you calling me that? And so that's why, you know, we're going to be taking a real shift in PopSeg 2.0 to get more of that kind of patient member voice. Again, I don't think it invalidates the pattern, the algorithm, you know, what we're seeing, but words are really powerful, and how you utilize them will either make or break your interventions. And so, you know, really taking that to heart when we got that feedback from our advisory panels, I think was really important. And I would advise anyone who's embarking on this, if you haven't done that, you know, learn from our mistake and involve them in really early, I think is critical.
Yeah, I just wanted to make a comment about the involving patients and providers in this work. So I think, as Anna mentioned, the providers at Kaiser have been very involved in as practitioners in helping to define the work that both she did and Richard Grant. So we've done a lot of work around engaging them in making sure that the definitions make sense on a practical level. And but in terms of the patient piece, that's also been really important. And I would say one specific area is around, I mentioned earlier this goal around more around social needs screening, more upstream. And so for that, we've been working with a team who does human-centered design to really understand how to do that in practice with patients. And I think, as Jonathan said, one thing that's really important is the language piece we have found has been really key. So this idea of really normalizing social needs screening and thinking about, you know, and so we actually have very bad language for social needs screening, like social determinants of health, social health. It does not really mean a whole lot to patients. And I think it does create some awkwardness for both the providers and the patients as we start to think more about this upstream. So the more we can think about language that is meaningful to both patients and providers and really generates trust, I think is really important. So that's one of the things we've been thinking about as well.
I think on the clinical application part of things, having patients involved from the very beginning is really, really important. I think the original impetus for the safety net clinic at Bellevue when it first got started was these patients who just were not being served by general primary care, were not being served by the emergency room, and like figuring out what could possibly serve them better. Some of the lessons that we learned there were that, you know, not punishing patients if they're really late to their appointment or missing their appointment times was something that was really important for our patients. Having available phone numbers where they can call and get in touch with us if they do have a phone, getting them cell phones if they don't have access to them, like things like that has really made, I think, really been like one of the keys to our success in like getting our bonds with our patients. Because yeah, it's like, it's often stuff that wouldn't necessarily come to my mind in like my general primary care flow of things, but really has made a big difference for them.
That's great. Thank you so much. Maybe I'll just ask one more question that I feel like is kind of part of the bucket of questions specifically around identification strategies, which is, I think a topic that has been on our mind, our collective minds, I should say, probably for the last 12 months or so, which is around bias. There's been at least one really high profile example of a healthcare identification algorithm that unintentionally seemingly had racial bias built into it, and really impacted the way that people were being directed to or not being directed to care. And so curious if any of the panelists on the line have just given this topic thought, have built in measures to try and be particularly sensitive to that, or if this is still a space that we need to grapple with some more.
So I would love to touch on this, and I'll start by saying it's absolutely a space that we need to grapple on more. I think one place where bias can rear its head is when subjective approaches are used for population selection. So when an individual person is making a determination based on their own instinct or reactions. These might be biases about who's likely to be engageable or who may be a good candidate for a program. Also biases about who's likely to be impactable or be responsive to treatment versus non-responsive. But there's also, as you touched on, good evidence for bias in data-driven methods of population selection. Machine learning approaches will they will do what you train them to do, and they're only as good as the data that you feed them. And oftentimes our underlying data do have biases inherent in them based simply on the way they are collected. There's the pretty high profile example of Amazon's recruitment screening methodology that perpetuated gender biases for quite a while until they realized that it was favoring male candidates. In healthcare, at the most innocuous level, this can look like having more missingness of data for populations that are have worse access to care or are underserved. But there are certainly more worrisome types of bias beyond the missingness issue that really merit a lot of attention and require very careful effort to avoid.
Great. Thank you, Anna. I really appreciate that. So how about as a next question, there's a lot of folks that have sort of asked a variation on the question of like, now what? Now that you've got this data, how do you intervene with or engage or outreach to patients? And so maybe I'll start there. Curious if any of you have found that better understanding your population has changed the way that you think about the initial step of connecting with and engaging patients to try and pull them into any services that are tailored for them.
So absolutely for our patients, in particular, because we're catching most of our patients are homeless and we find them in the emergency, or they're all homeless, but we either find them in the emergency room or in like a hospital admission setting. That's the majority. So really like making that connection right at the start, like while they're still admitted, has been really important for our success here at Woodhull, and introducing them to their care transitions team member, their care coordinator while they're still admitted, and giving them a big piece of paper that says, this is your appointment time. This is when you're gonna come see us. Just making it real clear and simple has been one thing that we learned, like, again, like the regular way of doing business wasn't really working. Everyone was no showing. We weren't getting any patients to come. So we had to switch things up once we realized that, yeah, people didn't trust us. Why would they trust us until we met them? So yeah, that was helpful for us.
Yeah, and I would say similarly, for us, it was almost like before it was a one size fits all sort of situation. We just called people, we tried to engage people. But when it came to really patient engagement, it was so different because you could see where they were getting care, right? So if they were in their PCP and they were seeing their PCP a whole bunch of times and we wanted to intervene, what would be the point of us just cold calling them, right? We don't have the relationship. The primary care provider has the relationship. So how do we give the primary care provider the tools in order to engage that person maybe differently? And then similar to what Jillian was saying, at the hospital level, lots of folks who weren't going to primary care, that was the place that we could intervene and connect with them. So how did we get more real-time notifications so we could get there, so we could, collaborate to get them back to a primary care provider, I think was really important. So certainly in terms of engagement, it really changed how we thought about and our success in terms of engaging folks in that process, I think really made a difference.
That's great, thank you. So not surprisingly, we are also getting a lot of questions about how you guys are measuring the success of your work here. Maybe one way to sort of package up the questions in that vein that we've received is just, how are you guys thinking about tracking or measuring performance of your efforts or programs that have become a little bit more finely targeted through this population identification? Is success measured differently? Anything along the lines of measuring or impact that you guys could speak to, I think would be of great interest to folks on the line. Perhaps not surprisingly, nobody wants to chime in on this one. I guess maybe I'll just start with a more basic question, which is, are you guys feeling like you need to be refining the typical approach to tracking outcomes or thinking about what it means to have impactful programs based on, doing more work in this space, or are the approaches that you've been using previously fairly transferable?
Yeah, Rachel, I think that this is the crux of one of the challenges of this work is that this is a bias, but I think the toolkit that we have for measuring the impact of these programs is insufficient. So I think one of the things is, I think that's why the population identification work is so critical, because part of it is, can we be a little bit more precise around how we're allocating resources to the patients that most need it, and put in sort of those more high cost, high intensive programs to patients who need it. And then maybe think about, how do we scale more broadly, sort of more proactive approaches for screening that may not require as much cost. I think that's part of the challenge. So I think part of it is, so I think we are looking at, cost and utilization, but I think part of it is there a better way also for us to start to think through patient-reported outcomes? Like, how do we really understand the impact of these programs from a patient perspective? And then I think there's this other part around this trust piece. Are there ways that we can, which I don't know if we have defined, are there ways that we can maybe actually measure the impact of these programs on trust? Because we hear when we interview members or patients and we talk to providers, we really do, if you're in the work, you can see it. You can see that the work is really having an impact on these patients. You can see that it's generating joy in work, that it's generating teamness, but it can sound a little touchy-feely. It's hard to kind of translate that into actual numbers that you can share with people that fund work. So I think that's part of the challenge, and I look forward to the field sort of helping to develop that toolkit for our patients and our practitioners.
I wanted to just add for our safety net clinic, we actually developed a dashboard with our data analytics team that our clinical teams actually use. On those dashboards, we can basically compare our engaged patients to folks who may have been referred and were not engaged. And we look at a couple of different measures. Obviously, we can pull things like diagnoses really easily from health records, but also average primary care engagement, acute care utilization engagement. And we can see some differences, certainly in the populations that we're working with and those that we have not yet been able to reach. But I think there's more work to be done there. I think eventually we would like to do a propensity score match type approach to really evaluate it more robustly. And the other thing I just wanted to add, we did do a series of patient interviews pre-COVID about a year ago. I think we spoke to 15 of our patients at Bellevue, really just to get a sense of what their experiences were in care within our safety net clinic, if they had had other care experiences within our system and sort of how those compared, and just wanted to get a sense of, from their perspective, were we offering the right things to address their needs? So that was also really helpful. And obviously that's not something that can be gotten easily from the electronic health record. That's really something you need to hear from the patients directly.
That's great. So we have time for one, maybe two more questions. So maybe I'll ask something that I think Anne-Marie and Jonathan, you guys both alluded to a bit, or maybe Jillian, it was during your portion of the presentation, but this idea of recognizing that once we have better insight into the needs of population subgroups and the risk drivers, sort of having that expand potentially your sense of who you might need to be partnering with to help shore up and connect patients to services that really meet their needs. We had a question about where HCBS services fit into your work. So I think, just to kind of roll that up and broaden it, would just love to hear, what you guys have really learned or taken away from this process or put into place that's been about kind of this partnership piece beyond the core services that traditionally you might have offered before understanding, before getting a broader sense of patient needs.
I think for us, we started to broaden our perspective of that yours, mine, and ours concept, right? We were really thinking provider, health plan, us together. And what we realized is yours is, community-based organizations. It's, we would say, oh, they're not engaged. What we meant was not engaged in primary care, but they're engaged. They're engaged somewhere else. They're engaged with their church, with their community-based organization, with their cultural center, with all these different things, And I think once we kind of opened our eyes to that, we were able to say, oh, okay, this truly is like a community perspective, right? A provider has a role, we have a role, community has a role, and then how do we bring that together? So we actually created kind of a 2-year collaborative process with a variety of community-based organizations where we are paying them to work with our members in collaboration with us to kind of address some of those needs that we've been talking about. And it really is the learning collaborative. It's us coming together and saying we speak different languages, literally and figuratively. Culturally, we're different. We have different payment mechanisms. We don't understand each other. How do we come together to say, how are we going to work and partner with each other on these patients who need us, right? Need us to help those connections happen. And so we just started that process, but I'm hopeful within that end of that 2-year period, we'll have a real clear connection about what is appropriate and how can we pay for those services. I think it's really important that we talk about social determinants, we talk about social health, we talk about all these things, but we don't have a mechanism or an infrastructure to pay people to do that critical work. So that is also kind of this juxtaposition of like, how do we address those two things at the same time, which is really complicated. But that, to your point, Rachel, I mean, that's what we realized with all complex patients, right? We go, whoa, this is way beyond just two people or us. It's the whole community has to come together, and you have to listen to the patient. You got to hear what the patient wants and what they need. And so I do think it is a lot about bringing in other partners and being really mindful that if you're a health system, how you bring in those partners is very critical, because it can go sideways really quickly. So we're trying to be really thoughtful about that.
That's great. And Jonathan, your mention of sort of paying partners is interesting and jogged my memory. Anna and Michelle, I know KP is huge. This isn't your guys' department per se, but it just jogged my memory that you know, I think as part and parcel of this bigger conversation, there's really fascinating examples, including in KP, of health systems and payers deciding to invest in some of these social supports like housing. And so I think that's just like an interesting and probably much needed phenomenon that's coming out of our, you know, our increasingly understanding the various needs that are driving the complexities that patients can grapple with. Anne-Marie, let me give you one more minute to respond here before we wrap up the Q&A portion.
Just really quickly, one of the things that's been really successful in our safety net clinic work is a partnership with a community-based organization that's really an expert in housing. So we actually contract with them directly, and we have a social worker that's part of their organization, but serves our patients to provide housing navigation services, help with completing supportive housing applications. And the really nice thing about this partnership too is that they can affect patients beyond just the safety net patients they're helping directly. They've helped train social work staff at our hospitals. We've brought them on for, you know, lunch and learns with different teams, so that some of the skills that they use working directly with their patients can be replicated by other staff within our healthcare system. But it's really great to have that knowledge base and to be working, because there are so many shared patients that we have.
That's wonderful. Well, I feel like we could probably stay on the line for another 2 hours. You guys are just incredible thought partners in this space. Thank you so much for joining us today and sharing your insights. We have just a couple minutes here. I'll turn it back over to my colleague Emma to get us wrapped up. But thank you, Jillian, Jonathan, Anna, Anne-Marie, Michelle. You guys were terrific. Thank you so much.
Thank you, Rachel. Wow, that was really just a fantastic set of presentations and super rich conversations in our Q&A. Thank you to the audience members for being really engaged as well. We got a lot of questions from you all, and we'll do our best to follow up with responses to those after the webinar. And thank you, Rachel, for moderating with amazing skill, of course. So in the slide, I just wanted to share that we did include all of the links for the various resources that you heard about today. If you'd like to dig in and learn more about the work these organizations are doing, you can go to the next slide, Travis. And finally, if you have any resources that you would like to share, whether it's a report, journal article, tool, we'd love to hear from you and welcome submissions on the Playbook website. You know, we're really trying to build a community here where it's just like about sharing, you know, the information that we're learning and best practices. And we really welcome to hear from you all. So thank you again to our excellent speakers and to our participants for joining today's webinar. And thank you to the 7 Foundation Collaborative for supporting the webinar as well. So please submit your evaluation survey. We really value this feedback and we use it to shape future Playbook content. Thanks again, everyone, and have a wonderful rest of your day.